Hello, I am Stacey Evans-Charles and I am the Tissue Viability Lead for NHS Highland. Today I will be discussing antimicrobial stewardship in tissue viability. The aims and objectives for today will look at what antimicrobial stewardship is, antimicrobial stewardship in relation to tissue viability, recognize when to use antibiotics in wound care, apply evidence-based practice in tissue viability, and be a responsible user of antimicrobials using the NHS Highland infection and biofilm pathway. So why does antimicrobial stewardship matter? Well, it remains a global concern where inappropriate use of antibiotics contributes to antimicrobial drug and wound dressing resistance. Furthermore, nurses can play a crucial role in reducing the risk of antimicrobial drug and dressing resistance. Antimicrobial stewardship is everyone's business. And by this, I mean that the use of antimicrobial dressings, antibacterial, antifungal, and antiviral, as well as antiparasitic medications, must be utilized in a manner that prevents its overuse and its inappropriate use. The principles of antimicrobial stewardship dictate that we only prescribe when infection is clinically evident, that we choose the right antibiotic, the right dose, and the right duration, that we review and stop antibiotics when infection resolves, and in particular, be aware that hand hygiene and good wound hygiene can prevent infections from spreading. Microbiology of wound infections. We know that there are common organisms such as Staphylococcus aureus and Pseudomonas aeruginosa, as well as polymicrobial biofilms that contribute to delayed wound healing. We know that there's a need to be sure of when a wound is showing signs of colonization versus infection, and that colonization exists when bacteria is present with no tissue damage. Critical colonization involves delayed wound healing with no systemic signs of infection, whilst infection is evident when there is systemic response due to microbacterial overload. So what are the signs of local versus systemic infection? With localized infection, there may be symptoms and signs such as heat, odor, pain, and erythema. With systemic infection or rising incidence of sepsis, there is fever, malaise, possibly elevated white blood cell count, and spreading cellulitis. Some of the diagnostic tools and wound assessment interventions that we would undertake as part of understanding the patient and the patient's response to wound infection or wound colonization would be via a holistic wound assessment of the patient and the wound, whereby a wound swab or wound or tissue biopsy alongside CRP or white blood cell count in blood tests, or infection scoring tools such as NERDs or stones may also be part of that diagnostic tool and holistic assessment. When to use antibiotics. So we use antibiotics when there is spreading or systemic infection, when there is evidence of cellulitis, when there is suspected osteomyelitis, when there is confirmed bacterial infection, as in blood cultures. We should not use antibiotics when the wounds are deemed to be colonized but stable, when malodor or slough with no systemic signs of infection are present, or when biofilm on its own is present. We should also not use antibiotics when there is lack of clinical signs of infection, as highlighted above. There are, of course, systemic antibiotics as well as topical antibiotics. Topical antibiotics can be used for short-term local infection management, whilst systemic antibiotics are used for deep or spreading infections. Some of the antimicrobial dressings that you may come across include silvers, honey, iodine-based antimicrobial dressings. However, it needs to be highlighted that there should not be a replacement for systemic infection where indicated. So if your patient is showing signs of systemic infection, antimicrobial dressings should not be utilized on its own. The patient should be treated for systemic infection. Biofilms. Biofilms are bacteria that colonize and cause long-term chronic wound presentation. They occur in 5 stages, as you can see from this diagram, and in particular, they affect chronic wounds and prevent these wounds from healing, keeping them stuck in the inflammatory state. It is important to be aware of biofilms, as we may, as clinicians, be able to interject their growth on wounds at the attachment or stage 1, where bacteria attach to the wound using tail-like structures. And then this particular stage is actually reversible. This is the stage where clinicians need to be involved with preventing the growth, maturation, detachment, and redevelopment stage. So stage 1 is the key stage of preventing biofilms from growing and developing on chronic wounds, and can be done simply by a pathway such as the infection and biofilm pathway, which looks at disrupting biofilm development. Before we go on to look at biofilms in its entirety, I wanted to share with you some information around risk stratification and biofilm. That is, how we can use data to inform our decision making. In May 2024 to April 25, we were able to liaise with the infection team and the microbiology lab, and we were able to obtain some very important information looking at wound samples. We were able to determine that of a total of 2,519 wound swab samples within the time frame as above, 1,620 patients had wound swabs that detected 103 organisms. Of that data, we were also able to break down the demographics into gender, where females during the time frame of May 2024 to April 2025 tended to have more wound swabs done. And for the male and female population, the age range of 71 to 80 accounted for the highest demographic group of patients who had wound swabs between that time frame. And when we compare gender and time of the year, We can also see that in the month of October 2024, there were more wound swabs undertaken in that time frame. And again, the age group of 71 to 80 can be seen to be the highest age group accounting for wound swabs in the month of October 2024. We were also able to break down that data in terms of the wound organisms. And in part 1, part 2, and part 3, and in particular part 3, we can see that per every 1,000, Staphylococcus aureus accounted for the highest number of wound organism accountable for wound swabs, followed by Streptococcus, then your Pseudomonas, and E. coli. So that data has helped us to understand where there are trends in wound swabs and how we as clinicians can contribute to antimicrobial stewardship. We were able to form a picture that during this time of May 2024 to April 2025, we had a higher female population between the ages of 71 to 80 in the month of October who had very high wound swab results. We were also able to determine the wound organisms that were of the highest number affecting wounds during that time frame. And so we were able to determine that Staphylococcus aureus, being a bacterium that can cause a wound infection that lives on the skin normally, is a bacteria that we need to pay particular attention and understand how we can reduce the risk of patients becoming susceptible to this infection, utilizing a systematic process in the form of the NHS Highland infection and biofilm management pathway, which looked at informing clinicians, firstly, of what biofilm actually are, and that they actually affect more than 60 to 80% of chronic wounds or hard to heal wounds, and that there is a process that we should be following for reducing that risk of patients developing infection as a result of Staphylococcus aureus risk or Streptococcus, Pseudomonas, or E. coli through this process of hand hygiene, undertaking a systematic intervention at stage 1 to prevent biofilm from attaching to the wound through effective debridement of that chronic wound, and through application of appropriate antimicrobial dressings. And what you can see on this pathway is that it's color-coded. So you have a pathway that indicates when a wound may show signs of contamination, colonization, localized infection, right throughout systemic infection, where a patient will need to be treated for sepsis, but can have antimicrobial dressings applied to that wound whilst they're being treated for systemic infection. The pathway also looks at giving clinicians an opportunity to recognize when a biofilm will be present through some of the symptoms that the wound may present with, such as delayed healing, extra exudate, malodor, slough, and so forth. And the pathway makes some very clear recommendations in addition to the guidelines. What's particularly useful with this document, in addition to being systematic, it also highlights what antimicrobial dressings are available to clinicians and when to undertake use of these antimicrobial dressings, and at what stages they can be used, and when to recognize that a patient is progressing from a contaminated wound right throughout that systemic infection, seeking emergency medical assistance. We will now apply this risk stratification of data in partnership with the infection and biofilm management pathway, using a case study of an 83-year-old male with a chronic venous leg ulcer that showed signs of increased exudate, heavy malodor, and thick yellow slough to that ulcer. He also had no fever or spreading erythema, so there was a decision to not give him antibiotics, but to optimize wound bed preparation. So that would be cleansing the leg, cleansing the wound bed, debriding the slough with the appropriate care plan, which we will go through, and apply evidence-based practice for management of venous leg ulcers using NICE guidelines and the application of compression therapy bandages. So this gentleman's care plan included washing the lower limb and pat drying, applying emollient to the whole limb, using a debridement pad to disrupt the biofilm as per your formulary, and then applying an antimicrobial agent such as Flaminol Forte or possibly Flaminol Hydro if the slough was very thick and dry, with the intent of helping to reduce and debride that slough, as Flaminol Forte is an enzymatic alginate. There's also the option to use a honey-based ointment to deslough that wound, as well as flamazine. So depending on what is available on your formulary, there are options to help deslough that bioburden that is stopping your antimicrobials from working and stopping your dressings from working. You're then going to apply a barrier film to your wound bed and your peri-wound bed to protect the surrounding skin that may be healthy. You're going to apply a suitable absorbent pad based on the exudate. In order to manage the exudate levels, you would have to choose a pad, an absorbent pad, that is either for mild, moderate, or heavy exudate levels. Now, we've said that there was an increased level of exudate levels, so we would assume that there is a moderate to heavy exudate level for this wound. Therefore, we would want to choose a suitable absorbent pad as per your formulary. And then, of course, apply a toe to knee soft band, followed by your immediate and necessary care if this patient was not in compression therapy before. Your immediate and necessary care comes from the National Wound Care Strategy, where it stipulates that immediately escalate to the relevant clinical specialist those patients that do not show red flag symptoms. Now, these red flag symptoms include acute infection, which may be swelling, pain, pus, heat, sepsis, acute or suspected limb-threatening ischemia, for example, your peripheral arterial disease, suspected acute deep vein thrombosis, suspected skin cancer, or a bleeding varicose vein. So if your patients are showing these signs, they must be escalated to the relevant clinical specialist, such as your vascular team. And in this scenario, your patient would not be suitable for reduced compression if they are showing signs of this red flag. If the patient, as per our case study, is not showing signs of this red flag scenario, we are able to apply reduced compression to this patient's leg with the intention of ensuring we carry out a comprehensive, full lower limb assessment within 14 days of applying reduced compression to his limb in order to improve his circulation and improve his wound healing of his leg ulcers. The comprehensive wound assessment would, through documentation, record the wound assessment and what infection signs, if any, or colonization signs, any interventions, such as when his ABPI and full lower limb assessment is due, any communication that would be taken with relevant teams, for example, the vascular team. For example, if he has diabetes, is his diabetes controlled? So from a multidisciplinary team, it's, are we communicating with the right clinicians? And then, of course, we'd also provide information for patients on lower limb care and compression therapy through the use of giving the patients information on good skin care, good skin hygiene, and a patient leg ulcer passport booklet, which we have from some of our colleagues, explaining to the patient why they're wearing compression, what the compression therapy bandage or compression therapy hosiery actually does for their legs and the veins, and how it improves that wound healing. And of course, we will also undertake some non-antibiotic interventions, such as good wound bed preparation. What do we need to prepare this wound? Do we need a debridement pad? What's the environment like? Wound hygiene and using the four-step approach, observing the wound, ensuring that we're providing adequate wound debridement, we're applying the right dressings, and that we're reviewing the wound progress effectively, that we're undertaking wound photography so that we always have some sort of comparator to go back to. Are we using the right debridement products? Are we using the right offloading and pressure redistribution, for example, in heels, in order to encourage wound healing? One important aspect that we also need to look at is adequate nutrition. Are we providing adequate nutrition for patients who are losing protein in excessive leg ulcer exudate? And are we addressing patient comorbidities such as lifestyle, such as their ability to exercise, their ability to manage their diabetes and any other long-term conditions? The role of the nurse in antimicrobial stewardship is about early identification and risk stratification of patients who are at a higher risk of developing infection in their wounds. For example, we already saw that within the time frame chosen, we had more females having wound swabs between the ages of 71 to 80. And in particular, in the month of October, where it's much more colder, patients develop flu, they develop bugs and diarrhea, and they become much more debilitated with their long-term conditions. Their reduced mobility, there's also reduced food and drink intake. And so it's about early identification of these high-risk group of patients and how we promote systematic pathways to identify our high-risk patients in order to prevent these groups of patients from developing infection. It's about educating our colleagues, patients, carers, and loved ones about their risk of wound infection and how we can reduce those risks through early identification of these groups of patients, and how we educate our colleagues to recognize early interventions and the effect that it has on reducing the overuse of antimicrobial dressings, whilst wanting to ensure that we have the patients get the right antimicrobials, either dressings or medication, at the right time and not before they are actually needed. Are we monitoring and recording and giving the appropriate information and sharing within the MDT team, including use of antibiotics? And how are we as clinicians ensuring that we have good hand hygiene and that we're washing our hands and getting the patients to wash their hands appropriately if there's a shared care partnership for patients who are undertaking and being proactive in their own wound care? So the key takeaway is antimicrobial stewardship is everyone's responsibility. Antibiotics are not always required in wound care, and using risk stratification in wound care helps reduce antimicrobial resistance and contributes to best practice in order to reduce patient harm through early interventions, recognizing when wounds are at risk of contamination versus actual infection, and using this evidence-based tissue viability service to support wound healing, particularly for hard-to-heal wounds, where reducing biofilm in chronic wounds is essential to healing. Thank you for listening to this short session, and I would be grateful and thankful to take any questions. Thank you. Hello, I am Stacey, and I'm just going through the webinar chat for some of your questions. Thank you for taking time out of your day to attend this session. So I'm going to go through the questions that were asked in order. The first question I have here is the biofilm and infection management pathway available online to view? This particular pathway is available for NHS Highland staff. You may have your own infection and biofilm pathway for your individual areas. So I would encourage you to liaise with your community nursing team and your tissue viability nurse team to ascertain if you do actually have your own individual infection and biofilm pathway for your area of work. Do antimicrobial dressings need to be considered in antimicrobial stewardship, or is stewardship mostly about oral antibiotics? To answer your question, antimicrobial dressings need to be considered as part of antimicrobial stewardship, primarily because there's a lot of research being done to suggest that antimicrobial dressings and, for example, silver are actually becoming very restricted in its use. So the silver dressings in particular has now been shown to not be as effective with the bacteria as it used 2 years ago. So there is some antimicrobial resistance to silver dressings. So we need to be very careful with the appropriate use of antimicrobial dressings, as well as antibiotics, oral antibiotics. Oops, sorry, I'm just going back up to that question. The other part to your question around the antimicrobial dressings is that, as you can see from this pathway, what we've done is used the antimicrobial dressings that are available on formulary for NHS Highland. So again, you may have slightly different or varying antimicrobial dressings. So it might be worth you getting in touch with your tissue viability team or community nursing team to understand what your antimicrobial dressings are, and so ensure that you're utilizing them at the right time, and knowing when to stop using them. So it's really important that you're aware of antimicrobial stewardship and applying it correctly to that patient, bearing in mind that there are some patients who will also have sort of chronic contamination or chronic localized infection. And, you know, when you do your wound swab and the GP refuses to give antibiotics, it's equally important to liaise from a multidisciplinary point of view, to liaise with your infection control team, because they may also say, well, actually, this patient may need a full body decontamination. So equally, it's also important to be aware of your infection control policy for managing things like Staph aureus, where your patient will need full body decontamination. Question 3, I'm working in social care. We would escalate to the TVN, but this might not take place within 14 days due to workload. What can we do if TVNs? Okay, that's a really important question. And the reason that we developed this infection and biofilm pathway was actually to give autonomy to clinicians to commence, to be able to recognize when a wound was infected, when a wound was colonized, when a wound was locally infected, and when a patient was showing signs of systemic infection. So your pathways are designed to empower you as clinicians. So if you're recognizing that your patient is at risk of developing localized infection, you'll choose whatever antimicrobial dressing is there, while you're awaiting the assistance of your tissue viability nurses. And this is where training and knowledge and awareness of pathways and products and appropriate use of products for your area is important. So that's what I would do. I would ensure that I am aware of what products are available for my patients, recognize the wound type, how long that patient has had that wound for, what's a bit available on my formulary, and which other networks I need to form as part of that holistic patient care planning. So once you have your pathways, you should immediately be following your individual trust pathways while you're awaiting assistance. And of course, recognizing if your patient is heading towards that systemic infection, it's important to get hold of your GP, but certainly start applying your antimicrobial dressings if you think that the wounds are showing signs of chronic infection. And most people these days have Cutimed sore-backed. And again, depending on the presentation of the wound, your care plan must be individualized and must indicate what you're using and why you're using it, and that sort of review. So you're having a continuum. What is the aim of your intervention? Review it and renew your care plan accordingly. What are the best ways to reduce biofilm in chronic wounds? That is not an easy question, but again, using debridement to continuously disrupt the biofilm is the best way to reduce biofilm in chronic wounds. So what the pathway has already alluded to is that you've already got biofilm in 60 to 80%, and it's now actually been proven that in chronic wounds, over 80% of chronic wounds have a biofilm or fungi. So it's not just bacteria. There's actually fungus in the wounds. There are viruses in the wounds. And it's important to be able to recognize the stages of wound healing, the stages of infection, in order to know how to reduce that biofilm. But essentially, it's about good hand hygiene. It's about ensuring that you've got the right products, the right debridement aids, and the right, oops, sorry, the chat's jumping. So the right debridement aids, the right cleansing solutions, knowing your patient. So is your patient immunocompromised compromised? What's the state of your patient, the patient as a host for that bacteria? What is the health of your patient like? Are they exhibiting signs of wound infection? How is the wound affecting your patient? So it's about knowing your patients and formulating an individualized care plan, ensuring that you're also giving the patient the right information to make the right decisions, and sometimes having to compromise, um, because what you may want for that wound isn't necessarily what the patient wants for that wound. So your patient, for example, with a leg ulcer that's very malodorous, may just want to get rid of the smell of the wet legs because they still want to go out. They still want to go out. So you need to agree with the patient what the aims of your interventions are. And if in the community, for example, if you've got a shared patient approach to wound care, or you're sharing patient dressing days, so practice nurses, community nurses, and the patients being involved in that care plan, it's about what all of you have agreed as an outcome for that intervention. So that's what I would say is the best way to reduce biofilm. You're looking to improve concordance with the patient for your care plan. And that would be via agreeing what the patient wants as an outcome for that intervention, in addition to ensuring that you're being cost effective, being proactive, and that you've got all the right products to support with wound healing, because the products do not heal the wounds. The products actually address the issues or the presentation of the wound. So you've got to address that element as well as the patient elements. Is your patient eating a balanced diet? Is your patient's comorbidities being addressed? Is your patient willing to walk more, to wear compression bandages, compression hosiery? Are they have you got the right resources available? So that's what I would do to reduce biofilm. It's a combination. No one jacket will fit everyone. It's about individualizing your patients. Question 4. Question 5. How do we encourage better antimicrobial stewardship within your team? I would say that you need to recognize your role with simple hand hygiene, encouraging your patient to wash their hands adequately. And I know that in most areas, there is a hand washing sort of audit that your infection control team does with you in the community and in the acute setting. So I would say to you, it's basic hand hygiene. It's knowing when to use oral and systemic antibiotics. It's about knowing the type of bacteria that is present in the wound, and knowing how to do wound swabs effectively and when to actually wound swab. What we have found as a result of, which wasn't presented in this presentation slide, but some of the other information that we were acquiring as a result of the audit that gave rise to this biofilm pathway was that people were just randomly doing wound swabs. Why are you doing a wound swab? Because we just thought we'd do one. Or patients would have wound swabs done, but they weren't being reviewed. So patients weren't getting the right treatment. So the wounds just continued to deteriorate because the wounds weren't treated appropriately, either with systemic antibiotics or with topical antimicrobial dressings. So basically, it's about having continuity within your care plan. It's also about knowing when to actually wound swab, what to do with the wound swab results, and how to encourage your patient and your clinicians to do the basics, which is your hand hygiene, and ensure that you're following the pathway, liaising with your infection control team. So again, this is an antimicrobial stewardship partnership with your infection control team. and that you're walking even with hand gels for patient homes that you don't feel comfortable to wash hands in. So that's how you can build that antimicrobial stewardship. And each of your areas will also have, as part of the infection control team, people who are very, very much into antimicrobial stewardship. So it's about reading up what antimicrobial stewardship groups and awareness documents are available within your individual areas, and what your area of work, so your trust, your board, are actually doing as part of raising awareness of antimicrobial stewardship and correct use of oral antibiotics, including GPs and practice nurses. So I hope I've answered your question to how can we encourage better antimicrobial stewardship, and again, following your infection and biofilm pathways. Question 6 asks, is biofilm visible? That's the reason I'm laughing, right? When I was doing my master's in tissue viability, we had this very question asked, is biofilm visible? Some people seem to think that biofilm is actually visible via that jelly-like presentation on the wound bed, whilst most people would say, well, actually, no, biofilm is not visible because they're actually very microscopic organisms that cannot be seen with the naked eye. So I would go along with that suggestion that we can assume that any chronic wound is made up of colonies of biofilm, which may not necessarily be an infection. It can actually be a contaminated wound bed. It can be a colonized wound bed, but not necessarily a biofilm colony. However, you can also assume that biofilm is present, because what we do know is that biofilm stops wounds from going in that healing trajectory. So if your wounds are not showing signs of improvement despite good hand washing, good wound dressing intervention, good wound bed preparation, you can assume that that wound chronicity or that delayed wound healing is being caused by biofilm colonies. And so it would be in your best interest to ensure that you're cleansing and debriding and choosing the right antimicrobial dressings, and that your care plan is suitable for that patient. The next question is, advice to use only antibiotics when resident. So for Michelle, you've highlighted that you have been advised to only use antimicrobial dressings when the resident is on an antibiotic. I would liaise with the tissue viability nurse for your team, because you're actually trying to prevent that patient being on oral antibiotics through the appropriate use of the correct antimicrobial dressing. So it's the recognition, and this is where the pathway comes in. It's about recognizing that that chronic wound, that wound that is not healing effectively, that wound that is not healing in that trajectory and not healing effectively, will have a biofilm, and you're trying to prevent that patient from going on oral antibiotics. And again, it's about ensuring that you're being cost effective with your antimicrobials. So that's not quite correct. However, you can use antimicrobial dressings alongside oral or IV antibiotics, when your patients are showing signs of sort of systemic infection. Okay. Can you share the biofilm? I am happy for that, for the pathway, the NHS Highland infection and biofilm pathway to be shared with you. However, I would suggest that you also liaise and link in with your own tissue viability team or wound care nurses. I know some areas have wound care nurse specialists or tissue viability nurses, and ascertain if you have your own version of a biofilm pathway or an infection and biofilm pathway that you should be aware of, and sort of make use of that. Equally, I'm also happy to share the pathway for NHS Highland with you, and present it to your area. However, I would strongly recommend that you first of all link in with your tissue viability or wound care nurse team. Okay, should you swab the wound before or after cleaning? You should swab a wound before, sorry, you should clean the wound before you swab. So you clean the wound with sterile normal saline, and then you do a deep wound swab. So there is a need for the team and for clinicians, including healthcare support workers who do wound swabs, to be aware of the systematic approach to undertaking wound swabs. So you should clean the wound with normal saline prior to undertaking a wound swab. And the reason you're cleaning the wound with normal saline prior to taking the wound swab is that you're removing debris, which can be from the wound dressing itself. So you're removing debris from the wound bed. You're also removing sort of bacteria that may be superficial and that can give you a false positive reading. So you're sort of removing risk associated with a false negative or a false positive in order to ascertain what bacteria is actually causing that delayed wound healing. So you're going to clean the wound with sterile normal saline, and then using your method. Now, there are three methods for undertaking wound swabs. There's that Z technique, there is your SN rotary method, and there's another method that I can't quite remember the name of it, because we tend to use the SN rotary method. And this SN rotary method ensures that you're going only within the edges of the wound. So you're not going over the wound bed itself. You've cleaned the wound bed with normal saline. You apply that spiral in motion using a sort of a zigzag approach, ensuring that you're collecting the sample, and you're applying slight pressure to that wound bed to sort of milk exudate upwards from the wound in order to capture the numbers of bacteria, which will be evident when the lab does the sampling. So you're using your technique, whatever technique is used in your area, and you're applying slight pressure to the wound bed to milk the wound bed to get the actual true bacteria up onto the wound bed. Okay, so the answer to your question is yes, you should be cleaning the wound with normal saline prior to swabbing. So if a wound is not healing with an antimicrobial dressing, does it mean that it requires an antibiotic? And the short answer to that is not necessarily. So you should be forming a holistic photographic memory of what your patient is like. Does your patient have comorbidities? What are their long-term conditions? Are they compliant? Are you addressing the barriers, the sort of barriers for the patient? In terms of antimicrobial dressings, dressings do not heal wounds. Dressings manage symptoms of the wound. So you need to ascertain what is the cause of that wound. Is that wound due to surgical intervention? Is it cancerous? Is it an actual pressure ulcer? What caused that wound? In addition to the dressings that you're choosing to manage the symptoms, you're also addressing the causation of that wound. So if it is that it's pressure related, is that patient having the right pressure relief? Is that patient requiring equipment that will offload the pressure? And you're going to be doing an assessment that addresses those needs. You're going to be doing your skin checks. You're going to be looking at equipment, whether that patient is able to move themselves or needs assistance to do such. What are their incontinence needs? what are their nutritional state? Have we given the patient the right information to make the right choices at that point in time to improve concordance to the care plan? If the antimicrobial dressing is not working, is it the right antimicrobial dressing for that wound type? What are we trying to achieve? And that's where your care plan's aim is particularly important, and the agreement with the patient, their loved one, relatives become important in understanding. So it's not just about dressings. The dressings do not heal the wounds. The dressings manage symptoms. We're looking at what caused the wound in the first place and addressing a holistic intervention for that patient. Okay, so I hope I've answered your question. Okay, should you swab the wound? Okay, so yeah, and I think I've answered the question around should you swab the wound before or after cleansing? As I said, you clean the wound with normal saline. And I think that's all the questions that came in. But yes, thank you very much, Michelle. And thank you. Thank you all. Any other questions? Thanks, Jennifer. Ooh. I hope I've answered all your questions. And if there's any other information, I've got one here. Do you provide wound management? Yes. Yes, we do, Amy. And so, Amy, to answer you, thank you. So, Amy, to answer your question about malignant cancer wounds, again, it's individualizing that care plan. So, and also working with the palliative team as a. Okay, Amy, where do you work exactly? What area geographically? Because it might be worth getting hold of your palliative nurses in terms of pain management. So what the things that you need to address with patients with malignant wounds, and there's some new guidance out as well, which looks at malignant wounds. Do you mind if I would be, okay, brilliant. What I'm going to do, I'm going to share in here the link for, happy for you to say about the survey and to scan it and then wrap it up. Okay. So, Amy, I'm going to share with you some new guidelines, the new consensus document on managing malignant wounds. So I'll put that link in here. And in terms of the, no worries. And in terms of the survey, so what we did, we were finding that there were I'm just giving you a bit of background to the infection and biofilm pathway and how this came about. So in addition to wounds being swabbed and patients not having the correct treatment for actual wounds, we decided to undertake a series of data looking at wound swabs and carry out some training sessions on when to actually wound swab. And some of the things that came up in terms of this information and the results of this audit actually showed us that what was happening is that staff didn't know when to actually swab a wound. Staff weren't able to understand the interventions and the processes for undertaking a wound swab. So some of these questions that were presented here today actually highlighted itself as a result of the audit. So some of the questions we'd get from clinicians, Amy, this is for you. This is your consensus on malignant wounds, okay? And it gives you a lot of information in there about managing odor, debriding and when not to debride. And then the other thing I'd encourage you as well is to make contact with your palliative care team as well as your tissue viability nurses so that you're working in partnership with your team. Yeah. So so we did the audit, we got the results. They were asking the exact same questions. How do I know if a wound is chronic? How do I know if a wound is infected? How do I know when wounds have biofilm? And how do we prevent it? How do we work with patients? How do we get concordance? What do we do? Can patients use oral antibiotics as well as dressings? So that's how this pathway was introduced. So thank you all for all your questions, and feel free to put anything else towards the presenters here, which are phenomenal. Thank you all.